Good evening and a very warm welcome to everyone to this National Game Changer Symposium. I am Dr. Shabir, the medical advisor of the GLP portfolio of Novo Nordisk. And it gives me an immense pleasure to welcome you all for an exciting scientific symposium where we have some of the nation's biggest and well-known clinicians in the field of diabetes. We have a power-packed session coming up where we will discuss on the science of oral semaglutide along with the effect of oral semaglutide in the CV risk factors and its role in ASCVD. We will also be seeing some of the real world experiences by our own faculty on how has oral semaglutide performed in their clinical practice. Now, to take the proceedings ahead, I would like to invite today's chairperson, and it's an honor and privilege to introduce Dr. K. M. Prasannakumar sir, who is currently heading the Center for Diabetes and Endocrine Care in Bangalore. He's also been the former senior professor and HOD of endocrinology of MS Ramaya Medical College, Bangalore. He's been president of many societies, including RSSDI, ESI, Indian Thyroid Society, and also the director of Primer. He has been the chairman for changing diabetes in children between 2011 and 2014. He has authored numerous publications, both international and national, over 150 so far, and he's been the member of editorial board of one of the most important journal of India, which is International Journal for Diabetes in Developing Countries. He has also edited many books, numerous books, including Women's Health Newsletters, Handbook of Diabetes, Primary Year Book of 2012. He is also a guest editor of the book on thyroid disorders. He's been the member of Ethics Committee of MS Ramaya Medical College and also the chairman for the committee to draft curriculum on diabetes and other non-communicable diseases for schools, undergraduates, and postgraduates in Karnataka for a very long time. It's truly an honor, sir, and a very warm welcome to you. I now request you to take over the proceedings. Over to you, sir.
Good evening, everybody. Thank you, Dr. Shabir, for the introduction. Today, we have a very important symposium on the game changer. What is the game changer? That is GLP-1 receptor analog, that too in a world form. We have got three excellent speakers. The first speaker is Dr. Debamalya Sanyal, endocrinologist. Then we have got Dr. Rajiv Agarwal, cardiologist. Lastly, we have got another speaker who is a diabetologist as well, Manoj Chowdhury. So like that, we have got three speakers. And let me introduce Dr. Debamalya Sanyal, who is DTM, MD, MRCP, DM Endocrinology, Professor, Department of Endocrinology from KPC Medical College, Kolkata. He is also Conjoint Professor, School of Medicine, Public Health, University of Newcastle. He is a visiting senior consultant, NHRTICS Diabetes Institute, Kolkata, and Editor's Choice Publication in Diabetes India 2021. He has received many awards, has many publications, reviewers for many of the journals as such reputed one. And it's over to Dr. Debamalya Sanyal to speak about GLP-1 receptor analog oral semaglutide in the management of diabetes. Over to Dr. Debamalya Sanyal.
Thank you, sir. Thank you for the kind introduction. Now, we have been using the GLP-1 group of molecules for quite a long time, but till we had oral semaglutide, it was mainly the injectable GLP-1. Previously, it was we started off with twice daily exenatide. Then we moved on to once daily GLP-1, and then even once weekly GLP-1s, but all were injectables. With regards to the oral semaglutide, this has been a game changer in the management of type 2 diabetes. Next slide, please. So this is a very important innovation and a giant leap in the diabetes management, because the problem is we are all aware of the impact on weight, on glycemic control, on cardiovascular benefit of GLP-1 group of drugs, especially liraglutide and injectable semaglutide as well. But the problem was the acceptability with an injection, especially early on. To derive a greatest benefit, we need to use as early as possible. And if you see the recent ADA, ASD consensus statement, they have even disposed of metformin, especially in patients who have cardiorenal risk. In such a population, even GLP-1 group of medications and SGLT2 inhibitors are actually now being prescribed or being recommended as first-line therapy prior to metformin as well. But the problem was with injectable. The acceptability with injectable therapy significantly diminishes until and unless we have an oral therapy. Next slide, please. So from insulin, the first discovery of insulin, we have just completed 100 years of insulin discovery. We have had significant modifications in insulin with the coming of insulin analogs, but GLP-1 has been really a game changer in true sense, and especially the oral GLP-1 semaglutide. Next slide, please. So obviously, if you look at it in terms of preference with regards to vials and syringes, patients obviously prefer once daily pen injections, which are more comfortable, and obviously once weekly is preferred more, which we have seen even with GLP-1 use, that the once weekly GLP-1s were more acceptable than the daily GLP-1s. But obviously, the most preferred will always be an oral tablet, because we still have a significant amount of needle phobia, which will be there persistent. And this is across the board, not only in India, but across the world as well. Next slide. So, the issue with regards to the GLP-1 group of medication is with regards to the peptide, because these are protein molecules. These are susceptible to enzymatic degradation, especially in the GI tract, especially in the stomach. And also there is a limited permeability, so the absorption is limited, and that these two account for significant decrease in oral bioavailability and leads to limited absorption. Now, this can be overcome, of course, next slide, please, by inducing enzymatic stability. Not only that, there can be improved permeability, and this is, we can improve the permeability by transcellular transport, and also by modification with regard to time of administration, we can also improve the bioavailability as well. Next slide, please. So if we look at it, insulin or GLP-1 with regards to oral use, there is now, if you see across the board, all the guidelines suggest, even as an injectable therapy, GLP-1 is the first injectable which should be used because of lower risk of hypoglycemia. In fact, if it is used with metformin or agents which do not cause hypoglycemia, the hypoglycemia is not increased. And along with that, you have a weight gain. Both of these are important handicaps of insulin uses, whether it is hypoglycemia or weight gain, in spite of the latest generation of insulin analogs which fare much better, but still they have these handicaps as well. So in terms of safety, these, obviously GLP-1 scores, and on top of that, you have added benefit of weight loss and cardiorenal benefit as well. Next slide. So most guidelines prefer the GLP-1 over insulin in terms of first injectable therapy because of longer duration of action, because of better glycemic control. Also, that has been seen lower weight gain and minimal hypoglycemia apart from the cardiorenal benefits. Now, the foundation stone of oral GLP-1 was semaglutide. If you look at the semaglutide molecule, this has 94% homology with human GLP-1, and especially with regards to its substitution at the position 8 that prevents the DPP-4 degradation, adding the spacer, especially along with the fatty acid derivative moiety, that reduces renal clearance. And also there is another substitution at position 34 which prevents the fatty acid moiety from binding with the wrong side. So all these modification in the structures of GLP-1 have led to a significant prolonged duration of action, and also there, especially once snack is also used along with that, then the absorption of this molecule is significantly increased. So one is they have a prolonged duration of action, about 7 days. Then there is a DPP-4 stability, as we have seen. oral bioavailability with oral semaglutide. It is hydrophilic, and it has demonstrated significant benefit, and it has a long half-life. Along with that, it has cardiovascular benefit. It has benefit in terms of reducing weight, and especially we have seen that if there is a significant weight loss more than 5%, especially if it is 5 to 10%, it can significantly improve outcomes like NASH. It can also, if it is more than 15% weight loss, we can have actually diabetes, at least reversal for some time period. Then beyond glycemia, we have benefit in terms of CKD, especially in terms of decrease in proteinuria. Then we have some neurological benefits in terms of decrease in Alzheimer's disease, which have been shown with GLP-1 group of drugs. You have benefit in terms of obstructive sleep apnea as well. So the higher the degree of weight loss, the greater the benefit. And apart from that, we have benefit which are extra glycemic benefits as well, which actually lead to, a situation where these molecules are preferred compared to the other group of agents. Next slide, please. So if we look at the oral semaglutide, one, it has a proteolytic inhibitor, permeability enhancer, and also this is specifically targeted where there is improvement in GI absorption as well. So for this, we require a simple molecule which will lead to improved absorption, and that absorption enhancer is SNAC. We are already aware we have a semaglutide, which is the most potent GLP-1 available till date, which has a long half-life of 1 week. Use of oral formulation does not decrease the half-life, but use of the SNAC, which is an absorption enhancer, which promotes the semaglutide absorption and increases its bioavailability, that leads to a significant availability of oral semaglutide when it is co-formulated with a fixed dose of 300 milligram of SNAC. What has been seen is that if we increase the dose of SNAC, or even if we decrease the dose of SNAC, this absorption is not that much as we get it with 300 milligrams. So that is the optimal amount. So this is very important to remember practically also, because we cannot half the tablets, because then the SNAC become half, then the absorption is prevented. Similarly, a lot of patients, when they were shifted from 3 milligram to 7 milligram, some of them ask, they have 2-3 tablets to spare. So do they take 2 tablets at a time? So that would benefit as well, because then you have a SNAC of 600 milligram. That will also not help in absorption, rather the absorption will be further worsen. So you require that 300 milligram SNAC. Neither can you take 2 tablets, nor can you make the tablets half. That is very important to remember as well. Next slide. So with SNAC and semaglutide, what happens is SNAC causes a transient localized increase in pH, which protects the semaglutide from the proteolytic degradation of semaglutide in the stomach. Not only that, SNAC also facilitates a highly localized absorption of semaglutide across the gastric mucosa in a concentration dependent manner, and this is basically a transcellular absorption which is occurring. So that leads to a significant improvement in absorption. One, there is a localized increase in pH and prevention of proteolytic degradation, and secondly, there is a transcellular absorption. Next slide. So very important, with this absorption enhancer, the bioavailability actually is increased significantly, but it is still low, about 1%. There is still a variability of absorption. These are the limitations, but this is mitigated by one major advantage, is one that this oral GLP-1 semaglutide has a 1 week half-life, and we can do with once daily dosing, and we also have the advantage of several treatment doses, and that also can be tapered according to the patient's tolerability. So it has been seen, especially in the Pioneer study, where in one of the studies, probably in Pioneer Flex 7, Pioneer 7, where there was a flexible dosing of semaglutide, where just like real life, if the patients couldn't tolerate, the dose was cut down to half, or it was even stopped for a few days. And once the tolerability increases, again, the dose was increased subsequently. So we can titrate the dose, and because of multiple doses formulation, we can actually get to the optimum dose for that particular patient as well. So that is a major advantage of this group of medications. And in terms of bioavailability, compared to the similar doses of injectable SEMA versus oral SEMA, there is similar bioavailability, similar duration of action, similar efficacy in terms of HbA1c lowering. So oral semaglutide is a wonderful technological innovation which allows for the first time the efficacy and safety of GLP-1 to be preserved in an oral tablet. Next slide. So we need to take this molecule on empty stomach, and this is very important because medications or any other food can interfere with the absorption. And what has been seen is the optimal duration is at least we need to wait for 30 minutes before eating, drinking, or taking any other oral medications. What has been seen is that that is the minimum duration below which the absorption is hindered. Again, the amount of water needed is approximately 120 ml. It has been seen with compared with 60 ml and increased water, which further dilutes the concentration. So the absorption is no better. So probably if we can wait for 60 minutes, the absorption is slightly better, but that is not significantly different. So at least we need to wait for 30 minutes, and the water amount along with that has to be 120 ml. We start off with a dose of 3 milligram starting dose. After 1 month, we up titrate to 7 milligram dose, and subsequently after 2 months, in those patients where further glycemic control is needed, we can up titrate to 14 milligram. Though there has been some studies, and we have also seen as well that in patients who have been receiving other GLP-1 group of drugs, including injectable GLP-1s, what we do is, because the tolerability is no longer that big an issue, we may, this is actually not a recommendation, but a practical observation which we have seen, we may start in patients with on prior GLP-1 therapy, we can start off with a 7 milligram dose, but otherwise we start off with a low dose and gradually build up and up titrate. We can actually, if there is some patients have problems with regards to tolerability of higher doses like 14 milligram, then if there is some problem with tolerability, we can cut down. We can actually wait, and after some point of time, people can again be up titrated as well. Next slide, please. Now, the pioneer studies are the clinical efficacy studies of oral semaglutide. Next slide, please. So, if you see, it has been compared in various clinical programs, compared to placebo, compared to SGLT2 inhibitor, compared to DPP4 inhibitor, compared to GLP-1 as well. And as I was mentioning, the Pioneer 7, the flexible dosing with DPP4 inhibitor, Pioneer 8 as an add-on to insulin, which had nearly 50 Indian subjects. Also Pioneer 5 in renally impaired patients, and also Pioneer 6, a CVOT trial. This was basically a non-inferiority trial, not a superiority trial, short duration trial. So it was intended to show non-inferiority, not to show superiority as well. And we have the ongoing SOUL trial, which is a superiority CVOT trial as well. Next slide. So if you see across these studies, whether it is monotherapy, there is HbA1c reduction of 1.3% versus 1.5% with oral SEMA 7 and 14. 1.5% is the reduction. We have seen that if the HbA1c is on the higher side, more than 8.5 or 9, the HbA1c reduction can be more than 2% as well. With regards to in comparison with empagliflozin, there is a stark difference, 0.8% versus 1.3% 3% with 14 milligram of oral sema. With regards to sitagliptin, again 0.4 versus 1.1%. Very, very important compared to head-to-head comparison of liraglutide injectable, which is again a very potent GLP-1. This molecule had a better HbA1c reduction of 1.2% versus 0.9%. Again, with insulin, there was a better HbA1c reduction of 1.2% compared to insulin as well. So we have seen a superiority of oral semaglutide in terms of lira, in terms of empagliflozin, and also in terms of insulin. And the HbA1c reduction can cross up to 1.5%. In high HbA1c, it can go up to 2% as well. Next slide. Next slide, please. Next slide, please. So if we look at the weight loss across the trial, monotherapy, as you can see with the 14 milligram, is about 4 kgs. But if you see in most of our patients, this can be significantly higher in our population. Probably the GLP-1 group of medications are more effective in our population. It's about 4 to 5 kgs weight loss across the board. Again, very important, if you compare with empagliflozin, there is a greater weight loss, 3.8 versus 4.7. Very, very important. Again, another weight reducing agent, very potent agent, liraglutide, which is even approved as a weight loss agent. There you can see, though the dose of liraglutide was 1.8, the highest amount of liraglutide which is used, 3 kgs versus 5 kg with oral semaglutide 14 milligram. Obviously, compared to sitagliptin, which is better. And obviously, compared to insulin, it is significant. But standing out is the fact that even compared to liraglutide, there was significant improvement in weight. And across the board, the weight reduction is about 5 kgs, which is very, very significant. And it is as good as any anti-obesity agents as well. Next slide, please. So in summary, we have peptides which are challenging compounds because in terms of oral formulation, we need innovations to optimize their therapy and improve their absorption. So peptide analogs have been designed to improve stability and prolong the half-life, and also formulations like oral semaglutide, which can actually lead to the absorption of a peptide and leading to a peptide in a pill from the stomach. This can be absorbed because of localized rise in pH and inhibition of proteolytic degradation. Once it is used with a fixed dose co-formulation of SNAC, and it has been shown that the absorption is compound specific, it is transcellular. Very important, we have to maintain certain rules for its absorption. It has to be taken on empty stomach. We shouldn't be taking anything within half an hour, and an optimal amount of water not to exceed 120 ml. And other medications also should not be taken with this molecule. And this can lead to a significant improvement in outcome with regards to early use of this medication, which can lead to a significant amount of improvement in HbA1c control, more than 1.5%, even up to 2% reduction in HbA1c, a weight loss of about at least 5 kgs, which is actually better than most of the oral agents, and including it is better in terms of weight and HbA1c reduction in comparison to SGLT2 like empagliflozin and a GLP-1 like injectable liraglutide. And we also have safety data. We also have cardiovascular safety data as well, especially with oral semaglutide demonstrating cardiovascular safety in Pioneer 6 study as well. So this has been a truly game changer in terms of advancement in treatment with regards to diabetes, especially when treatment is associated with compliance to therapy, and that is significantly improved with this molecule. Thank you very much, and thank you for a patient hearing.
Thank you, Dr. Devamalya Sanyal, for an excellent talk. How he has told us a peptide in a pill, how oral GLP-1 receptor unlock is important in the management of type 2 diabetes, weight reduction, and HbA1c reduction, along with metformin and other drugs. He has told us about all pioneer drugs. Now we move on to our cardiologist, Dr. Rajiv Agarwal, and it's my pleasure to introduce Dr. Rajiv Agarwal, who is a doctorate in cardiology DM from GB Pant Hospital, Delhi, works equally in preventive and invasive cardiology and enjoys taking diabetes vascular disease. Actually, he enjoys talking about diabetes vascular disease. He has deep interest in vascular biology, especially diabetes, and he has been awarded many awards and including lifetime achievement awards. And we're going to listen to Dr. Rajiv Agarwal about his experience and opinion about GLP-1 receptor and semaglutide in cardiovascular disease. Over to Dr. Rajiv Agarwal.
Thank you, Dr. Prasanna Kumar. I need to get the clearance for screen sharing. I'm not able to screen share. Just a minute.
No,
yes,
now
yes, I'm able to do that. I hope I'm visible and audible both.
Yes.
Okay. Thank you. It's a pleasure to be in the company of endocrinologists because it provides an enormous opportunity to learn the other side of the story, how they look at it, how they feel about it. And I'm sure in next 15 minutes or so, I'll be sharing with you how, as cardiologist, as a vascular biologist, I look at GLP-1 receptor analog, which I very favorably called as glutides, vis-a-vis flozins. Many of you must be aware, Janus was a Greek god who has the ability to see both today and tomorrow. So I feel the management of diabetes is not only today's management, but we have to look and have a futuristic view that what kind of problems we are going to face in future. You can also say that it can be a vasculopathy approach or a hypoglycemic approach or a glucocentric approach. You can say microangiopathy or a macroangiopathy. So Janus applies very well to diabetes because we have to have at least two-dimensional view, both glucocentric and vasculocentric view. Simple diabetes means if you don't have diabetes, and diabetes, there is a loss of 6 years of life. If you have diabetes with one vascular compartment, which is macroangiopathy, you lose 12 years. And if you have two macroangiopathy with diabetes, that means a patient of stroke and an angioplasty patient having a diabetes, then you have loss of almost 2 decades. The another combination can be a peripheral arterial disease, stroke and diabetes, or cardiovascular disease, peripheral arterial disease and stroke and diabetes. So these are not unseen combinations in your clinical practice. What is interesting to note is that many of us are not charged efficiently and enormously to handle this upcoming problem. Another thing which is very interesting and to know is Yentl syndrome. Yentl was a Polish girl who disguised herself as a boy to learn Jewish religious culture, which was forbidden, and was ultimately picked up in Poland, in Warsaw, that she is a boy. So anything which is hidden and disguised is called Yentl syndrome. And how Yentl syndrome is applied in diabetes is females have very high incidence of cardiovascular disease or a vascular disease in diabetes. So it is called Yentl syndrome is alive and well nurtured even today. And many of us believe that diabetic females are not being looked after the way they should be. If I look at the secondary prevention strategies, there are 6 verticals. I'm not going to talk too much about them, but on 2 sides, One is the cholesterol risk reduction, which is the most documented, most rewarding strategy in vascular medicine. On the other side, on extreme right, is the latest addition that how we treat sugar, it makes a difference, and both flozin and glutides have come on that board. What is important on the extreme left is how you reduce LDL by bariatric surgery, by PCSK9, by statin, by bempedoic acid, it doesn't matter. What matters is the LDL level. So the reduction of LDL level is not agent specific, it is the level which is important. On the extreme right, it is a very important thing to understand. Maintaining HbA1c is important, but it is also very important how you reduce it. And that is where the agent specificity comes into picture. So two dimensions entirely different, but we lose agent specificity in cholesterol or LDL reduction, but we are very much interested how you reduce HbA1c in diabetic patient is a matter of concern. So why cardiologists are peeping in? We feel that management of or prevention of CAD in diabetes is now possible. It is not inevitable, and that's why I am on board. Glutides, as we call them famously, they work on pancreas, incretin system, adipose tissue, heart, brain, and favorably affect every dimension. Unlike SGLT2 receptors, the GLP-1 receptors are very broadly distributed all over the body. So the receptor-wise distribution is very different between SGLT2 and GLP receptors. As we know, if we reduce 1% increase in HbA1c, 10 to 30% increase in CVD, 25% increase in CV death, oral semaglutide reduces HbA1c, which you just listened. And that is how it reflects on different vascular compartments. And many of us believe that probably HbA1c reduction is not important. No, up to a point, it is very important. That means up to 6, 6.5, up to that. Beyond that, there is a linear relationship. But after that, there is a U-shaped relationship, whether it is death from any cause, acute myocardial infarction, heart failure, or stroke. Unlike LDL, which has got bottomless pit, the relationship of HbA1c in macroangiopathy is U-shaped, and the tighter control of sugar beyond a point does not result in any gain on vascular front. In fact, it increases the mortality. That is yet another difference between the two verticals. Semaglutide reduces body weight, as you have listened just now, that it is probably outscores any modality in terms of weight reduction. It can reduce up to 5 kgs. If you reduce that weight, there is 33% reduction in stroke, 50% reduction in coronary artery disease, and 70% reduction in all-cause mortality. So weight reduction per se is a very powerful denominator in secondary prevention and, of course, in primary prevention. How we look at that, the HSCRP, lipids, and systolic blood pressure both are reduced, where they are independent of weight reduction. The waist circumference is also reduced by 4.7 centimeter versus placebo. It is basically a weight-related phenomenon. So roughly mnemonics is 5 kg weight loss, 5 centimeter waist circumference, 5 millimeter of systolic blood pressure reduction. That is how I look at it. And these are very powerful surrogate markers of reduction of vascular risk. So LDL cholesterol, it is reduced. Triglyceride, they are reduced. But let me say, I don't use semaglutide for reduction of LDL and triglyceride. What I try to say that they are in the right direction. They are not in a wrong direction. We have powerful tools to reduce LDL cholesterol, to some extent triglyceride also, but what semaglutide does, the reduction is concordant. That means we want that the direction in which it should go, it is moving in that direction, because the reduction is very, very minuscule kind of thing when we look at overall reduction possible with lipid lowering therapy. There is 5% reduction, 5 millimeter reduction of systolic blood pressure, 13% risk of stroke, ischemic heart disease, heart failure, and 5% related to death. The ischemic heart disease, since the coronary perfuse and diastole is not much reduced, the systolic blood pressure directly causes stroke and heart failure by enlarging the heart. So maximum gain is in heart failure and stroke. Ischemic heart disease by any other therapy does not reduce that way with systolic blood pressure reduction, the way heart failure and stroke they reduce. This is very, very interesting slide, that the semaglutide or glutides, they reduce vascular inflammation and is far disproportionate to empagliflozin. And that is the catch point you should carry home, that glutides and oral semaglutide on head-on comparison, HSCRP is more reduced by semaglutide than empagliflozin. I have no hesitation in saying so that glutides and oral semaglutide are powerful anti-inflammatory drug, while empagliflozin is a very weak anti-inflammatory drug, although the direction is concordant the way we want it. So anti-inflammatory effects, which is very, very important, and very important for us in secondary prevention, because we know that even after LDL reduction, if your HSCRP is high, these patients are prone for recurrence of events. So one point you have to carry home is, so oral semaglutide and glutide is common, are far more powerful anti-inflammatory drug than flozins. If I look at the effects, you can see that they have wide variety of effects, and I always believe that they are powerful anti-inflammatory, and that's why anti-atherosclerotic drugs, which are very, very important in management of vascular disease. Oral semaglutide, since it reduces weight, it decreases the insulin dose, and it happens in at least more than 20% reduction of the initial dose. And if you look at the oral semaglutide, 14 milligram, and this is at 26 weeks. At 52 weeks, at least 1/3 of the patient will be requiring less insulin, while this figure is just 5.8 in placebo. So they are very important drugs in reduction in the dosage of insulin requirement or treatment. And you can imagine as an anti-inflammatory drug, at weight reduction drug. So these things translate into more than 20% reduction in insulin dosage requirement at 52 weeks, roughly at the end of year. So GLP-1 receptor analog, they are good glycemic control, good body weight, pleiotropic effects, and the risk of hypoglycemia is less. And I always say CV risk reduction is less in comparison to flozins, is more in comparison to flozins. Pleiotropic benefits are more, effect on body weight is more. They are powerful in comparison to SGLT2. So they are my very favorite drug when I talk of vascular atherosclerotic effect. They are far more powerful than SGLT2 inhibitors. This is not a true study, but a pooled data of SUSTAIN, which is subcutaneous semaglutide, PIONEER, which is oral, and if we combine both of them, there is 24% relative risk reduction of MACE. PIONEER was a non-inferiority trial, so it was not an outcome-based trial. We are waiting for SOUL to tell us about that. Should be available in 24, I believe, and then will be more affirmative and strong in terms of CV outcome data. At the moment, oral semaglutide is an effective guideline-directed weight-reducing agent we don't have an outcome data. Pooled analysis of Sustain and Pioneer shows 24% risk reduction for primary base. This is something I like. The blue is oral and this is subcutaneous. What Dr. Sanyal has also shown you that they match the same way. So logically, if semaglutide subcutaneous is working, why should not the oral semaglutide work? Because the blood levels are more or less same. You can superimpose on them. And that is where I make my case that we don't have an outcome data, but we have a strong, logical, collateral, surrogate evidence that this drug should be as effective as subcutaneous semaglutide in Sustain. So this is the blood levels with oral and subcutaneous, and this is just a diagrammatic representation. So GI tolerability and glycemic effects both are same. So the company has the Galilean prize the molecule got because this is a unique creation, not only for semaglutide, for times to come for other molecules which could not be given oral. And now there is a way to snack is a way where you can cover the molecule in an envelope and give it to body and it can be selectively absorbed. So this is a very good way to look at it. And what I'm trying to show, the blood levels and the side effect and the effects are superimposed on each other. Semaglutide reduces the risk of atherosclerotic events in CVOT outcomes, and mean life you gain is about 1.7 years. And I'm repeatedly saying we don't have a pioneer CV outcome data. We are doing a projection of Sustain, blood levels, side effects, and comparison. We don't have an outcome. So if you ask me at the end of the talk that do we have the outcome data with oral semaglutide, I'll say no, we are waiting, but there is enough evidence that it will work the same way. This is Dr. Budaliar, and he was very categorically saying that the GLP-1 receptor analog, they are more for atherosclerotic diseases, while the flozins are more for pump. So you have pump and pipes theory, which Dr. Sudhir Verma projected, and the drug which is working on pump is flozins. The drug which is working more on pipes is predominantly glutides, and oral semaglutide should not be the exception because it is moving in the same direction. So I'm bringing in Janus again that probably if your patient is primarily an atherosclerotic patient, glutides are the drug of choice, oral semaglutide. If your patient is a heart failure, kidney disease patient, then probably flozins are one on priority on board. But I'll say if you have an opportunity, both should be used because both the syndrome, they overlap a large majority of our patients. Weight reduction is the key in management of patients with vascular disease in secondary prevention. And then you have a collateral issue, upcoming therapies like volanesorsen. Pemafibrate has already failed and withdrawn. Anti-inflammatory drugs are already failed. We are waiting for LPA reduction outcomes. We don't have an outcome data with LPA. Also, all these therapies are well established: Inclisiran, bempedoic acid, and evenkumab. You have wizards sitting on board talking why the drug is being given as a top priority, because if you have a drug-naive patient, diabetic with vascular disease, probably they take a step one position on podium because they have proven outcome data. Metformin, although a very old friend, has not been ever subjected to double-blind placebo-controlled trial. And if the patient is already on metformin, then you have to add on these drugs despite good control of HbA1c because of mortality reduction. So agent-specific HbA1c reduction in vasculopathy in diabetes has become the dictate and order and science of today's medicine. This is a revascularization recommendation. The SKY is basically intervention cardiology society, but even then they have advised that GLP-1 receptor analog, they should be used in atherosclerotic patient. And it is always good idea to combine both. But if my patient has got predominantly atherosclerosis, I'll use GLP-1 receptor analog. If my patient is heart failure and kidney, then probably SGLT2 inhibitor will be my first choice. These slides I keep on showing to encourage physicians that if you invest in early years of management of diabetes, in putting additional cost, then the dividends are enormous in times to come. Because patients having longer life than ever before, because these patients will be now living longer and they will be facing vascular compartment problem, and your initial investment in HbA1c reduction by the newer agents, newer vascular agent, will give you enormous return. And probably I think that is what I want to try. And it's a fascinating set of compounds. They are safe, well tolerated, but unfortunately, they're not picked up. Till now, the problem was injectable, both subcutaneous semaglutide and liraglutide, but probably now we will have oral semaglutide, which will be our friend in need in secondary prevention. So I'll summarize that the safety of semaglutide is good. There is a non-inferiority trial. Pooled data and small studies suggest that we are in the right direction. And I'm sure in the outcome trial in times to come will go in the same direction as the earlier studies. And we have a favorable result and favorable concordant directions in systolic blood pressure, LDL, triglyceride, and very effectively in HSCRP. So ladies and gentlemen, I strongly propose in diabetic patient with vascular disease, you should use GLP-1 receptor. The percentage at the moment is 6-7% are clinicians are using. I think there is enormous opportunity and challenge to use these molecules to pass on vascular benefit in diabetic patient. Never forget when I was giving last lecture in Mumbai last month about lipids, one of the very enlightened audience asked me, Dr. Agarwal, never forget to talk about diet and exercise in diabetes on top of everything. So this is his suggestion, that never forget diet and exercise in diabetes. They continue to be the pillar and the foundation in management of vascular disease in diabetes. And I'll end up with Dr. Osler's quote, a good physician should not treat stenosis. A great physician treat the atherosclerosis. And this is a call to my colleagues in intervention cardiology, to my colleagues in clinical cardiology, that we should not be focused on obstructions. Atherosclerosis is a metabolic disease, and we should heal arteries. We should clean them when they need it, but we should never forget to heal them. Thank you very much.
Thank you, Dr. Rajiv Agarwal, for an excellent talk. We'll come back to you at the end when we have the panel discussion. I'm sure there are many questions for you from our audience who would like to know from cardiologists how you can place GLP-1 unlock, especially the peptide in a pill, and what is the cardiovascular risk. What are the studies you have already shown? What are the studies which are coming in future, like SOUL study, and what are its implications? Now we move on to the last lecture, and the last talk will be by Dr. Manoj Chawla.
Prasanna sir, can you see the screen? Oh, I think he logged out. So meanwhile, just to keep the yeah, sir is back. Yeah, you're on mute, sir.
Sorry. So thank you, Dr. Rajiv Agarwal, for an excellent talk on cardiovascular protection by the GLP-1 receptor unlock, especially the old semaglutide. You have shown us the previous studies, pioneer sustenance studies, and also we'll come back to you during the panel discussion about the future studies like SOUL study, how they are important when we are managing diabetes as such, and what is the importance of inflammation, anti-inflammatory drug. You have also showed us difference between the SGLT2 inhibitors and GLP-1. The next speaker is Dr. Manoj S. Chawla, and as he is traveling, he will not be here with us for the panel discussion or physically present, but his talk has been recorded. So we will show you his talk. At the end, if there are any questions to Manoj Chawla, the panel take it. It's my pleasure to introduce Manoj Chawla, who is the Director and Consulting Diabetologist, Lina Diabetes Care and Mumbai Diabetes Research Center. He's the director of it and also completed his MBBS and also his the diploma in diabetes, and he is attached to many clinical setup, and he was president of United Arab Diabetes Forum and coordinator Department of Diabetology, Asia Heart Institute, Bandra Kurla. He has been an avid researcher, many publications, many awards as such. Over to Dr. Manoj Chawla to how do you place the GLP-1 receptor unlock, especially the peptide in a pill, the oral anti-diabetic drug. Can you now please talk? Yes, Dr. Shabir.
Yes, sir. Playing, sir. Technical team, can we play Dr. Manoj's?
Dr. Manoj will be talking about evidence of to practice with oral semaglutide case studies discussion.
Good evening, everyone, and glad to be part of this wonderful discussion. The aspect that I'm going to be speaking about is to show some evidence to practice with this game-changing molecule, oral semaglutide, and sharing some case studies that we've seen situation success with, and then we could have more discussion in the presence of our chairperson, Dr. Prasanna Kumar. This is the financial disclosure that this has been commercially supported, and I'm contracted by Novo Nordisk for today's conversation. So let's directly dive into the two profiles that I would like to discuss. Our profile number one is a patient that we all tend to see in our clinics, somebody with uncontrolled type 2 diabetes despite multiple oral therapies, or what one call as polytherapy, polypills, and so on. So this 60-year-old male individual who has diabetes for over 10 years is currently on maximum tolerated dose of sulfonylurea and metformin and an SGLT2 inhibitor, has been now suggested to start with oral semaglutide, as we all understand that the correct dose to start this is with 3 milligram, which has been added for this patient. And the reason that oral sema has been added is because in spite of being on full dose of 3 OHs, this patient is not at target and has high HbA1c. How do we start oral semaglutide? As we've now been used to it over the last about 8-9 months, that we start with 3 milligram. We started it for this individual. Again, we repeat, because the HbA1c has not been improving and is not at target in spite of maximum tolerated OHs. The starting dose always should be 3 milligram, gradually to be titrated on a monthly basis to 7 milligram and then to 14 milligram as long as the patient can tolerate it. Having said that, in real world practice, sometimes you may up titrate. If the patient has no side effects, you may up titrate it a little earlier as well, which is what many of us are doing it. But yes, the ideal advice would be to give it a month's gap, 4 weeks at least, before we up titrate. Now we look at this individual's parameters and we look at the baseline HbA1c as 10.6. which is now at the end of 3 months come down to 7.7. BMI from 26.7 down to 24.4. Blood pressure remains good at 110/70. Some improvement in the lipids as well. LDL cholesterol coming down from 70 to 59. There's been a mean change in triglycerides, mainly from 102 to 100. The EGFR has improved a bit, with the UACR coming down from 40 to 12. So what are the benefits that Rybelsus has added given this patient of ours? Reduction in HbA1c, predominant benefit. Reduction in BMI and weight, again, a great benefit. Reduction in LDL cholesterol, urine albumin creatinine ratio, and resultant improvement in EGFR. So if we look at these parameters and we are able to clearly appreciate the change, we can see this significant drop in HbA1c. And with time to come, this patient should reach the target of 7 and below as we see the improvement on this weighted average over time. We see the EGFR has also improved from 98 to 101, LDL coming down, and the urine albumin creatinine ratio also reducing. So what we are seeing here for oral semaglutide is the fact that this patient, who's been a known person with diabetes for the last 10 years, but was not under glycemic target, in spite of taking multiple OADs, after initiation of oral semaglutide, there's been significant improvement in glycemic control, which has been observed as early as at the end of 3 months. I'm sure most of you would agree that as we continue this medication, in another 3 months, we should see patients like him touching a target below 7%, maybe even reaching a 6.5%. Apart from glycemic control, there are many benefits that we are seeing with oral semaglutide in the real world. One of them is weight reduction, which has been clearly appreciated here, the BMI coming down as well. And also the fact that you're getting other pleiotropic benefits in terms of some reduction in LDL cholesterol, urine albumin creatinine ratio, and preservation and improvement to some extent of the renal function. So the take-home message from this case is oral semaglutide can be considered for patients with type 2 diabetes who are uncontrolled despite of polytherapies. And that's important because before oral semaglutide, where we saw 3 or 4 drugs failing, our only resolve was that we should offer insulin therapy to such patients, as that was the only therapy in terms of glycemic efficacy that we saw that at whatever level the patient may be stuck, insulin will help us get this patient's sugars down and get them closer to target. Today, we have GLP-1 receptor agonist therapy, which has proven glycemic efficacy better than any of the other drugs, almost touching parallel to the efficacy of insulin at times, and should be considered as an option before insulin because of the multiple benefits in many such patients. So typically this gentleman here, failing to achieve target in spite of multiple OHAs, we offered oral semaglutide, and we can see gladly the benefits and reductions in HbA1c and overall improved metabolic control. We move to look at our case number 2, and this patient profile is somebody with diabetes with comorbidities. Our first case was somebody with diabetes with remaining out of control in spite of multiple and large dose of OHA. The second individual here is somebody with type 2 diabetes with comorbidities like hypertension and dyslipidemia. A younger individual comparatively, 48-year-old male, diabetes for last 6 years, currently on maximum tolerated dose of sulfonylurea, metformin, pioglitazone, along with the antihypertensives, statins, and fenofibrate for the mixed dyslipidemia we very often see in patients with diabetes like him. 48-year-old individual, diabetes for 6 years. Again, probably 30 to 40% of our practice in our clinics will be busy with seeing patients with similar profile, either sex, but in this age group between 40 to 50, who have comorbidities and who are struggling to reach to target. Like this individual, in spite of multiple therapies, is not at A1C target, and hence oral semaglutide has been added in his prescription. The reason for change, again, like the previous case, has been high HbA1c and failure to improve HbA1c in spite of multiple successive therapies over a period of last few months and years. We remind ourselves what is the dosing to start with. It is 3 milligram, as I mentioned earlier. The reason that we started here is no improvement in HbA1c. I would go ahead and say this patient, clearly someone who has risk factors, added risk factors with hypertension and dyslipidemia. So not only in terms of glycemic control and improvement there, we are also concerned about the vascular protection and GLP-1 again offering that benefit along with weight reduction. Starting dose 3 milligram to be gradually up titrated to 14 milligram, going through 3 to 7 and then 14 at 1 monthly interval. We look at the parameters for this patient of ours, started with an A1C of 11%, again, sulfonylurea, metformin, and pioglitazone. So 3 drugs. From a baseline of 11, we see the reduction coming down in 3 months to 8.2. And this is what typically we are seeing in the real world cases, that patients are responding with great reduction in HbA1c. So can an 11 come down to 8.2? Can a 10 come down to 7.6? Well, this is the numbers that we are seeing, and patients are really responding to that extent. BMI marginally decreased at this stage from 32.35 to 32.02. Body weight 1 kg reduction at the end of 3 months. Blood pressure from 130/84 to 125/90. LDL cholesterol, again, just like the previous case, we're seeing further reduction in LDL cholesterol, which means this patient who's already on statins and fibrates, we do have an option when we offer oral semaglutide not to up titrate the statins and wait and watch and do it only where required, because you will get some benefit, which is direct benefit as well as indirect benefit through improvements in glycemia and of course weight loss. The mean change in triglycerides was noticeable. This patient had hypertriglyceridemia, huge at 564 to begin with, and that's why he was on fibrates besides statin. We see the improvement coming down to 178 with the glycemic reduction. eGFR again improving marginally from 104 to 109. We look closely at some of the beneficial parameters again, and HbA1c from 11 to 8.2, triglycerides massive drop from 564 to 178, the eGFR going up from 104 to 109 at the end of 3 months, and the LDL levels dropping from 177 to 128 at the end of 3 months. So what is the take-home message for our second case? Well, this again is an interesting case, and I would say a very routine run-of-the-mill case. Both these cases that I've discussed are simple cases that we see patients struggling in spite of polypills, or patient again on significant oral drugs with comorbidities who are not reaching target. Oral semaglutide does fit in the bill. This patient had diabetes for last 6 years on triple drug combination, not able to achieve the glycemic target. Hence, oral semaglutide 3 milligram was initiated. Patient tolerated this well and allowed us to up titrate the dose to current dose of 14 milligram. The 14 milligram dose will be the continuous sustained dose for such a patient. The patient did achieve good A1C reduction, not at target yet. Again, for this patient over the next 3 months, we hope to see targets of 7 and below. There has been added benefits of reduction of triglycerides and LDL levels also. This supports the fact that oral semaglutide can have pleiotropic and does have pleiotropic benefits which go beyond glycemic control, which will provide reduction in at least the known risk factors for atherosclerotic cardiovascular disease. So these were the 2 simple cases that I thought would be important for us to take home. And these are the clinical situations where we can offer our patients benefits of oral semaglutide. With that, I thank you very much for joining in and hand it back to our chairperson for further discussions. Thank you so much.
Thank you, Dr. Manoj Chawla. And let us start with our panel discussion. And we have got 2 panelists here, Dr. Rajiv Agarwal, cardiologist. You can pose your questions to him, as well as we have got Dev Malya Sanyal, who is an endocrinologist who will answer your question. I have already some questions. I'll start posing these questions. Right? Dr. Sujata Chennai asks how to handle the nausea. Because Dr. Sanyal, you know that a lot of patients complain of nausea, and how frequently you get nausea, how many patients stop because of nausea vomiting, and how do you manage nausea that you see with oral semaglutide?
Yes, sir. Well, we have seen nausea, vomiting with all the GLP-1, even with we have published data, even with a 0.6 milligram liraglutide, there is a significant amount of nausea. But thankfully, what we have seen, especially with the 3 milligram of oral semaglutide, when we are starting off, the incidences of nausea are not that great. It's much less compared to the injectable GLP-1s. That's one reassuring fact. But the issue still remains, especially when we are up titrating from 3 to 7 and especially to 14 milligram. Some of the patients do complain of nausea and intolerance. One of the ways, especially with regards to up titration, is cutting back on the dose. But more important, telling the patient that they should take small, frequent meals rather than big meals, because if they have big meals, the gastric emptying is obviously decreased. That will further worsen the nausea. So small meals at a time, and avoiding fatty meals also is one of the way outs to do this as well. Small meals which are less fat rich, so that would help in addressing nausea as well. And in patients who are intolerant, temporary reduction of the dose may also help. Prokinetics may be beneficial in some studies, but we generally do not use prokinetics because that is the benefit which we want. But in some patients who are severely intolerant for a short period of time, we may give it to tide over temporarily.
Thank you. I agree with you. Start with a small dose. You already said 3 mg. 1 month you give 3 mg, then go to 7 mg 1 or 2 months, then go to 14. Please remember, everybody will not reach 14 mg. A lot of people stop at 3 mg, some go to 7 mg, and some of them go to 14. Suppose somebody has severe, it's not just nausea, if they get really vomiting. Nausea is something, as Dr. Sanyal has said, where it reduces appetite, and we want you to eat less and then have a fullness and all. So if they have nausea very severe, it is 14, come to 7. With 7, you have come to 3. If they have very severe nausea, vomiting, stop it. Otherwise, most of the patients will be able to manage. This question, Dr. Malya has already answered this, that can oral semaglutide be started 7 mg instead of 3 mg dose on GLP? He has already answered yes. If the patient has taken 3 months or beyond the injectable GLP-1 receptor unlock, you don't have to start with 3 mg because that is not the optimal dose. Start with 7 mg. After 1 month, you go to that. Here's a question from Dr. Harish Basera to Dr. Sanyal, that what is the ideal BMI to start Rybelsus in diabetic patient?
Actually, again, with regards to the BMI, if you look at the current guidelines, the guidelines suggest that, one group of patients where you require for cardiorenal benefits, BMI is not a consideration. So that is one important factor which we must remember. For cardiorenal risk factors or established cardiovascular disease, BMI is not a consideration because the benefits are independent of BMI. Second is with regards to hypoglycemia subgroup. Again, BMI is not a consideration where the patients are at an increased risk of hypoglycemia. Actually, if you see the recent KDIGO guidelines, which have been just again published along with ADA, they have suggested that you can actually use the GLP-1, even semaglutide, right up to ESRD as well. So that is a major advantage with this group of drugs. Obviously, there is a caveat of nausea and vomiting, which is increased in CK. Now comes with regards to BMI. Obviously, BMI, there is one nice guidelines which suggests, according to their European standards, BMI more than 27, one needs to start off only for weight consideration. But that is actually lower for us. The BMI cutoffs are obviously lower. 25 is the cutoff for obesity. So we can actually start off at any BMI, provided the patient requires weight reduction, hypoglycemia risk reduction, and cardiorenal risk reduction. So generally we can start independently of BMI, but overweight and obesity also, people would get additional weight loss benefit.
Thank you, Dr. Sanya. And you have mentioned about cardiovascular risk. Our cardiac expert, Dr. Rajiv Agarwal, is there. And you said today it is not glucose-centric. We want beyond that. That's why today we just don't want drugs which reduce blood sugar, but cardiovascular. There are two types of patients, those with a high cardiovascular risk and those who already had it, and whether it is primary, secondary prevention. What do you think, Dr. Rajiv Agarwal, when we should use these patients? Let us say from day one, is it necessary? Or those patients who have high cardiovascular risk, and what does the data show? You have already shown about SUSTAIN, Pioneer study and all that. Where exactly you should use these patients in diabetes?
You have asked me a very difficult question. The simplest answer is, If you are in secondary prevention, things are very easy. You go ahead, there is no issue. If you look at the leader trial, the 81% patients were of ASCVD vis-a-vis in EMPA-REG outcome where 99% patients were ASCVD. So there were some about 18-19% patients who are kind of high risk primary prevention kind of thing. So secondary prevention is crystal clear. There is no issue. Start. Primary prevention kind of thing where you don't have a manifested atherosclerosis. This is a difficulty. How you handle it? The simple way of handling is doing a Framingham risk score, calculating a coronary artery risk, atherosclerotic risk. If you are more than 20%, then you are justified to use it. Then there is another way to look at it. There are economic studies which have shown that if your coronary artery calcium score is more than 100, then GLP-1 receptor analog, they are cost effective in terms of their cost and outcomes. So if you are coming as a pure diabetes with no imaged or expressed atherosclerosis, low Framingham risk score, no coronary artery calcium, I'll say we don't have a data to justify GLP-1 receptor analog. Only just yesterday, the cost-effective analysis has come, which has shown that GLP-1 receptor analog will be cost-effective if you reduce price by 70%. This is just the other day. So secondary prevention, crystal ball is clear. Primary prevention, Framingham risk score, ACC risk calculator, the way we calculate it for statins in primary prevention, hypertension you can use, or a coronary artery calcium score, which is a surrogate marker of atherosclerosis. If the score is more than 100, you have a subgroup analysis which suggests that it is cost effective. That is how I look at it.
Thank you very much. I thought Dr. Manoj Chavda will not be available, but he is available. We are lucky. I think he has made it. He must have landed in Bombay just now, right? So they said his flight is delayed. We will have questions.
I managed to join in. Yes, thank you.
Thank you very much. Now we have given some 2-3 case reports, how it is useful. Irrespective A1C is 11 or 10, it will still come down. And in excellent cases, real world case, how it's useful. We all know how it is indicated, right? Now people would like to know, Dr. Manoj, whether any contraindications for use of semaglutide, irrespective whether it is oral or injectable. Of course, injectable will come next year, but does not matter. What are the contraindications?
So, great question. And again, apologies for joining in late. So the pure contraindications is related largely to tolerability. So one aspect is tolerability of the drug, be it oral or injectable. Patients with a history of GI diseases, poor intolerance, and again, some of them who probably will have not history, but will just not tolerate, be able to have this drug, whether in terms of nausea, vomiting, just not feeling up to it. These are some of the patients where we will not be able to continue with the benefit of the drug. Now, beyond this, well, there is obviously the contraindication with patients with history of whether it is the MEN syndromes or medullary carcinoma of thyroid, which fortunately we do not see in those numbers in at least our population. There were concerns earlier with connects with any of the carcinoma of pancreas and pancreatitis. Largely in various meta-analysis and RCTs and even cardiovascular outcome trials, which have looked for years, we haven't found any connect. But probably patients with history of pancreatitis, you may still avoid this entire incretin therapy till we get more clarity. Though there is no link, but we'll probably avoid it in those patients who had a history of pancreatitis. So beyond these, most of the patients, we should be able to offer them the benefit. And I did hear some great discussion by Dr. Agarwal and Dr. Sanyal in terms of secondary prevention. Clearly, the path is very clear, but I would go a step ahead that there in patients with high risk factors, clearly established ASCVD, again, primary prevention being offered through these drugs is of great potential and help to the patients.
Thank you. You have answered Dr. H.K. Jain's question. Here's a question to Dr. Sanyal. Actually, part of it has been answered by Dr. Rajiv Agarwal clearly when he showed difference between SGLT2 and GLP-1. However, because there's a question directly on this, in kidney compromised patient, which is better, Yampa or Ribelsus?
Well, there is no doubt with regards to the fact that in renally impaired patients, and the guidelines are also absolutely clear. If you look at now the recent KDIGO publication, the first line therapy is obviously SGLT2 inhibitors. So that takes precedence over any of the GLP-1 because they are the hard renal outcome data and they have dedicated renal outcome studies as well. So that is very important. They have dedicated renal outcome studies, and it is advocated to use those molecules which have dedicated renal outcome studies. And they have showed the hard renal outcome data. Now, after that, or in patients where SGLT2 is contraindicated, like when the GFR goes below 20, or the patient is having recurrent UTIs, where you cannot use this molecule, then as an alternative, you can use as next line, GLP-1 is recommended as a next line of therapy, or where you require additional glycemic control, because one important fact we must remember when we are using an SGLT2 inhibitor in a renally impaired patient, the efficacy in terms of glycemic lowering is not that great. So there we would require additional agents to lower the blood glucose because you require that for benefit of other systems as well. So there the GLP-1 efficacy is not decreased, and that's why in such a scenario for additional benefit as well as decrease in albuminuria, the next preferred line of therapy would be a GLP-1, and where they are intolerant, again GLP-1 is advocated.
Thank you very much.
And if I can just add to that, I think for oral sema, they have the flow study ongoing, which is going to be dedicated in this space. We'll probably answer more questions in terms of whether there are really any renal benefits and renal endpoint benefits, and we wait for that.
I agree with you. And Dr. Yes, sir, Rajiv Agarwal.
I'll say there is a meta-analysis which was published in Lancet about glutides and their effect on heart failure and kidney outcomes. So there is 11-12% decrease in events on kidney front and 13-14% on heart failure. And the mechanistic they talked about as anti-inflammatory effect in renal progression and stabilization of plaque in heart failure progression. Because every heart failure, there is ongoing progression and subclinical events which leads to progression of heart failure. So GLP-1 receptor analog, by anti-atherosclerotic effect, they stabilize plaque and they reduce progression of the disease. But as Dr. Sanyal said, we have far more powerful drug in terms of flozins on these two compartments.
Since you are talking about plaque stabilization, there is a question for you. This is a peculiar question I have not heard last 8 months. This question is, considering the pleiotropic effect of semaglutide, can the dose of high moderate intensity statins be downgraded to moderate intensity or low intensity in diabetic patient with cardiovascular risk factors?
And this is interesting, but you see, our targets are very, very brutal now. And we are struggling with drugs, 1 drug, 2 drugs, 3 drugs, that kind of thing, like patients who have diabetes and atherosclerosis. Our target is definitely less than 50 in these situations. A large majority of patients, they need 2 drugs, and we have started talking like heart failure all together rather than sequential. Like hypertension, we have started talking combination pill rather than sequential. So I'll say this is a hypothetical question because the effect of these drugs are very, very mild in comparison to dedicated lipid lowering therapy. They can be just directional and supportive. I don't think, as a cardiologist, permit me to say so, and it should not annoy you. We look for 25 LDL, 30 LDL. That is the kind of secondary prevention LDL we are chasing for. And in that situation, we are using bempedoic acid, ezetimibe, and high intensity statin because 3 drugs are available relatively cheap. PCSK9 is still out of our bound because of affordability and once again injection. We are now working on oral PCSK9, which is a dream come true, like this oral semaglutide. Maybe in times to come we have, well, the phase 1 trials are already existing. They are safe and may have oral PCSK9, which is as effective as subcutaneous. We have similar graphs for oral PCSK9. So I'll say it is interesting to look at, but our targets are very brutal, very low. So these will be a good help, but not be a replacement.
And if in 4 or 5 decades, if one drug has made a change in cardiovascular disease, statin, no other drug has such data experience. Even if you tell me, I will not replace statins with anything. And because this is what is unfortunate, people thinking that whatever you say about other drugs, even PCSK inhibitors, anything, nothing can replace statin. That is the foundation. As you said, diet, exercise, statins are there, does not matter. Framingham risk is 20%, 30%, star statin at 40, because diabetics as such has 2 times higher risk. All others are not proved therapies, including this. And when you have something so cheap and best, evidence-based medicine, you should never replace statin with anything till you have some great reason to do.
I'll tell you a very interesting thing which should interest you as an endocrinologist. If you have the UKPDS subgroup analysis and Stano-2, they have quantified hypothetically the effects of all the parameters. So in UKPDS, the benefits are 56% related to LDL lowering, and the only competitor with LDL lowering is quitting smoking.
Yes.
That is another very important thing.
Yes.
HDL raising at that time was there, HbA1c, blood pressure reduction, all in 12-40% kind of thing. Disproportionate reduction by LDL lowering. Similarly, in Stano-2, the subgroup analysis and quantification of the effect is again 60% related to LDL lowering than other. So LDL lowering, which is not agent specific, is still the most powerful tool, as you said. And you are saying statin. We don't say statin, we say lipid lowering therapy, because you have now combinations. When we started, statin was the drug. Now majority of the patients are on many drugs, and we have started replacing statin to lipid lowering therapy. That is the only difference I can make.
Thank you very much. And I have last 1 or 2 questions because we are already exceeding time. This is a question to Dr. Manoj. Do GLP-1 receptor agonists serve any additional benefit on glycemic control when given with DPP-4 inhibitors?
Not really. If we're trying to combine these 2 drugs, no rationale in combining it. The question often asked is that going to be harmful? Well, they're not harmful as some may perceive, but there's absolutely no benefit. So you're wasting the money and do not use these 2 together.
I agree with you. When you start GLP-1 receptor unlock, please start DPP-4 inhibitors because both of them work to some extent in same way. There is no added advantage. Please stop DPP-4 inhibitors when the patient is on GSP. This is the last questions to Dr. Dev Malya Sanyal. The common side effects of semaglutide and maximum dose in Indian patients before I let go all 3 of them.
I think the common side effects which we have discussed is GI side effects, and generally they are mild and well tolerated if you follow the protocol of initiation and up titration. It's nausea, abdominal fullness, occasional vomiting and diarrhea, but you can deal with it as we have discussed previously. Now again, with regards to the maximum doses, again we shouldn't be starting at a maximum dose, starting off with the lowest possible dose, 3 milligram. Then after 1 month up titrating to 7 milligram, and in patients, mind you, only in those patients who require it for glycemic control, then only we need to up titrate to the maximum dose of 14 milligram. In majority of our patients, just like with the liraglutide 1.4, very few of our patients actually require and do tolerate liraglutide 1.8. Similarly, with oral semaglutide, I would say about only 30% required intensification to 14 milligram. Majority achieved our target with regards to standard targets with regards to a 7 milligram dose.
Thank you very much. I would like to thank Dr. Rajiv Agarwal, Dev Malya Sanyal, Manoj Chawla for an excellent talk, as well as we are fortunate to have Manoj Chawla at the end for question and answer session. I thank all the speakers and also thank Novo for giving me an opportunity to chair this session and learn a lot from my colleagues and cardiologists. Over to Dr. Shabir to conclude this session.
Yeah, thank you so much, sir. And yes, we have come to an end of an amazing scientific session, for which I would like to thank the speakers, Dr. Devmalya Sanil sir, for elaborating the innovation and science of oral sema, Dr. Rajiv sir for addressing the elephant in the room, ASCVD in diabetes, and how can oral semaglutide potentially help these patients, and finally the real world clinical cases narrated so beautifully by Dr. Manoj sir, alluding to the different profiles of the patients. Special thanks to you for squeezing this in during your travel as well. Thank you so much for that. And lastly, I would like to thank Dr. Prasanna Kumar sir to have been the chairperson for the session, navigating us through the discussions which are vital for clinical practice in diabetes, not only in terms of usage of oral semaglutide, but also the management of comorbidities of diabetes in everyday practice. So with that, I finally thank the audience for being here and supporting us with your active participation. Hope this program was helpful to you as it was for us. And until next time, from everyone here at Novo Nordisk GLP team, have a good night.
Thank you.
Thank you. Thank you. Good night,
Bye.
everyone. Thank you, Dr. Prasanna Kumar.
Thank you. Bye. Take care.
Bye. Good night, everyone.
Good night.
Bye, sir. Bye.